Hello, my name is Dr. Howard Paktovas. I'm a graduate of Tufts University School of Dental Medicine, 1975, and today we're here to do a little discussion on pain management in dentistry, what our approach is, what our overview is, just so that we have an understanding of the proper prescription technique and management of pain for our patients. One of the major reasons that we're here is because I show this picture of opiates and how they can affect the brain in many different places and the nervous system as far as that goes. The important thing to realize with that is that many of us are overprescribing, and our patients are asking for different medications. So we want to address those and understand that the opiates can have side effects. Some of the side effects are respiratory depression, sedation, obviously, urinary retention, mental clouding. All of those things enter into our discussions and understanding of how these drugs act on individuals. And the reason is that we may have some alternatives for our patients, whether it's an opioid, whether it's a non-steroidal. And we have to decide what is the appropriate prescribing for that individual. Every one of our patients is different. Every one of them has different needs, and we have to appreciate that, and we have to protect them, and we have to protect ourselves in the proper prescription techniques. First of all, what is pain? There are various physiological, physical, chemical approaches to the treatment, okay? There are different methods of pain control. It could be anything from anesthesias that we typically use to inhalation agents to ultimately the general anesthesia and intravenous sedations. But what is pain? Pain is an unpleasant sensory, emotional experience. Could be acute, could be have potential tissue damage, and it's described in many terms of causing damage. But ultimately, pain is, in reality, what the patient says it is. We have to understand that our patients are feeling individuals. They are reporting things to us, and we have to understand that that's their perception. So we look at that in terms of how to define and classify pain. Well, we classify it by its duration. Is it acute? Is it chronic? Is it constant or intermittent? What is the mechanism of the pain? Is it nociceptive, which we'll get into, or neuropathic, or visceral, or is it mixed? Is it coming from many different areas? And what disease process may be causing it? Is it muscular? Is it a peripheral neuropathy, a fibromyalgia? What exactly is causing the pain? And sometimes that's very difficult to determine. So, as we can see, because it's difficult to determine, things get confusing. So first we assess the pain. Many different factors can influence the pain that that individual is feeling. They could be physical, they could be emotional factors that enter into it and potentiate the pain. They could be genetic. Twins may feel things differently. They could be cultural, and we have to understand that we're treating many different cultures in our practices, and we have to understand that they do evaluate and experience pain in different manners. So in most cases, pain is self-reported. It's the individual themselves who report that they are in pain. This has to be considered along with our physical examination of the patient and our evaluation of the signs and symptoms of what may be causing the pain. Inadequate pain treatment is really a serious health problem in our country. Our course is really designed to provide an overview and addressing the understanding of both the treatment of acute and chronic pain. Management of pain is a cornerstone of compassionate practice. That's something that we all are. We're all professionals. We're all compassionate. We all want to treat our patients in the best and most compassionate way, and understanding that their pain is theirs, and to remove it is an essential in our daily practice. Pain assessment is not these things. It's not relying on the changes in vital signs. It's not deciding that someone doesn't look like they're in pain, or they might just be asleep. Or it's not deciding for them that something like our performing of a certain treatment shouldn't hurt them. Okay? So understand that the pain is the individual's. We have to determine where it's coming from and how best to treat it. Pain is defined as an unpleasant sensory and emotional experience. Okay? And that was defined by the International Association for the Study of Pain back in 2001. What we're here to do is really have a boot camp. Pain management. We know that pain is inevitable. We've all experienced pain over our lifetimes. The suffering aspect, that is optional. That's something that we can prevent and we can modify. There are many different types of pain. As I said, there are nociceptive and neuropathic. The nociceptive can be from somatic. It can be from bones, joints, teeth, as we can see here, or it could be from the organs, the tissues, the kidney, the liver, the pancreas. Many different areas can cause pain, or it could be neuropathic. In other words, it could be nerve generated from either the sympathetic or the peripheral nervous system. The nociceptive pain, breaking it down, it's a pain receptor stimulation from musculoskeletal system, a visceral pain, as we said, the organ systems, the bones, the joints, the tissues. The neuropathic, it may be from changes in the peripheral or central nervous system. Idiopathic pain, the third type, it's pain without a known cause. That's the most difficult for us to really understand and appreciate from our patients, because we may not see the exact reason for that pain, yet it still exists and it's something that the patient feels, and we have to appreciate that they are feeling that pain. The accurate assessment of the type of pain is really the critical aspect in determining what types of appropriate medications we can provide for our patient to reduce and alleviate that pain. Sometimes it'll require multiple approaches. Acute pain, breaking it down, it's a quick response to an illness or injury. It usually is time limited. It's usually responsive to treatment very quickly, and inadequate treatment, in other words, if we don't address the acute pain right away, we can really delay the recovery for that patient. Federation of State Medical Boards, okay, they define acute pain as normal, predicted physiological response to adverse chemical, thermal, mechanical stimulus. In other words, it's quick, it's usually time limited. Acute pain could be due to trauma. In other words, if we fall and hurt ourselves, or an acute medical or orthopedic problem. Okay? Postoperative pain is usually acute as well, although it can be chronic with some of the medical treatments that we do. The treatment of acute pain should be as effective as possible, and with this proper treatment, it will prevent the chronic pain from taking effect that could have the negative psychological and physical effects. The impact in our society and individually of acute pain is prolonged discomfort, loss of productivity, delayed recovery, and ultimately increased healthcare costs. The importance of effectively treating pain will minimize all of these. Research indicates the failure to treat them will lead to prolonged discomfort and prolonged recovery. Chronic pain, on the other hand, is a state of pain which persists beyond the usual course of acute, a healing injury, a chronic disease. Estimated that about one-third of the U.S. population suffers from chronic pain, and up to 9% of adults suffer from moderate to severe non-cancer related chronic pain. That's a huge number, and when we consider our population in our offices, again, it's a very large number. In addition, this is an amazing statistic. It's estimated about 15 to 20% of children suffer from chronic pain. This is something that we, as practitioners, we oftentimes don't really address properly. Accepted definition of chronic pain, it's persistent. It can be continuous or recurrent, and it can be of varying intensities. The impact of chronic pain has huge economic and social impacts. It's a major public health problem. Back in 1986, it was estimated that over $20 billion was the cost to our society from back pain alone. That's a huge number when you consider that that was well over 25 years ago. Estimated that U.S. businesses back then lost about $90 billion annually to sick time from chronic pain. Chronic pain is the major cause of healthcare consumption, and we're facing a healthcare crisis in this country, so we do have to address chronic pain, and that is really something that really goes unsaid. Chronic pain, single greatest source of healthcare consumption in this country. What can happen if we don't treat pain properly? Again, I'll emphasize the lost productivity, excessive healthcare expenditures, needless suffering. It could cause domestic problems for an individual or occupational problems certainly, and ultimately, in some cases, with a chronic pain that goes untreated, increased thoughts and risk of suicide. These factors alone have driven the economic burden of chronic pain well upwards of over $100 billion a year. Chronic pain is a major cause of healthcare consumption and disability in the United States. Its related causes are the single source of healthcare consumption and disability during an individual's working years. Inadequate pain treatment can lead to the following. We've said it before: loss of productivity, excessive healthcare expenditures, needless suffering for the individual, domestic problems. We oftentimes don't understand these, but they do occur. Occupational problems, increased thoughts of risk of suicide. These factors have driven the estimates of the economic burden of chronic pain as high as $100 billion annually, and that was over 10 years ago. We're well in excess of that now. In this section, we're going to discuss some of the pain management goals for our patients. Obviously, we want to reduce pain, we want to improve their functioning, and ultimately improve their quality of life. Our treatment goals, and here's an acronym that we've seen, it's called SMART. Our treatment goals should be specific, they should be able to be measured, they should be achievable, realistic, and also time-based. Appropriate consultations and referrals and diagnostic tests are necessary in order to provide all of these above. And timely follow-up is also a good cornerstone to pain management practice. If the treatment goals are not easily achieved, then we should ideally consult with others, okay? Consultation, referral. In other words, we want to emphasize a multidisciplinary approach to the treatment of pain. Pain should involve a team, and each member of the team should understand the anatomical and physiological basis of the pain perception, some of the psychological factors, and ultimately the basic principles of pain management. Effective management of severe and chronic pain will involve maybe more than one healthcare provider, and ultimately communication between these providers is very, very important. Communication in the team members is essential to report any changes and developments involving all of the specialists. And ultimately, we have to adhere to strict adherence to HIPAA, the Health Insurance Portability and Accountability Act. One of the aspects of that governs the privacy of the patient information. This is especially integrated when family members are part of the pain management team, because some of the family members will have a, quote, need to know, where others may not have that same need to know. So this is something that you should really evaluate quite closely before providing that pain and providing that information to the individual. Some of the key concepts in pain management: it is part of our routine dental practice. Several key concepts. Pain management should be considered in the recognition of that pain is essential. Most of the care and most of the pain management is done at the primary care dental level, and that's you, the provider. Majority should occur at the dental office level. Specialty evaluation treatment should follow the same patterns as established for any kind of your established referral basis in the practice. We look at some of the vulnerable populations. Inadequate pain management in vulnerable populations includes such as the children, the elderly, the cognitively impaired, and I'm sure that we all treat some of these in our daily practice. Ethnic minorities may have a different perception of pain, and the need to protect those individuals by educating providers on the proper pain management assessment and the treatment options. So there are certain questions that we have to start with. And we ask about pain. And we have the acronym here for pain. The pattern, in other words, the onset and duration of that pain. The area, where is it? Where is it coming from? The intensity, the level of pain, the variation of that, and the high or low levels. And the nature, the N, the description, in other words, what the patient feels about their own pain. And then we get into another acronym called PQRST, and it's a different format, and this is something that would be useful in your offices. What provokes the pain? What makes it start? The P, the provocation. The quality, what are the characteristics? Is it aching? Is it intermittent? Is it sharp? The referral, is it coming from another part of the body? The severity, how bad is it? And we'll look at a pain scale in just a moment. And the timing, when does it occur? Does it occur in the morning? Does it occur in the evening? Is it before you do something? Is it when you're chewing? Any different things like that. So the PQRST format is something that I would emphasize would be a very good implementation in your office. We see, as I said before, some of the pain assessment scales. There are visual and numeric scales. There's a pain face rating scale. Where it goes from 0 to 10 in terms of the severity. A location of pain painted on pictures. There's a McGill Pain Questionnaire. There are 20 subcategories and 78 words. That's rather excessive for the dental office, but nevertheless, I wanted to make you aware of all of the different pain assessment scales. In the assessment of pain, we have to look at the different factors that are involved. Is it in the developmental stage? Chronologically, what is the age of the individual, and how do they view it? What's their cognitive ability? What's their emotional status? And is there a cultural influence? Are they a minority feeling pain from certain outside sources? With the assessment of pain, we ask for the patient to self-report. We ask for the patient to tell us what they're feeling. How does it feel? Describe how you feel. Either write it down or describe it to us. For infants and children, we rely obviously on their caregivers, their parent, or an individual that cares for them. And we try to get some historical information. In other words, what is causing that pain? How long a duration? When we look at the OPQRST system of evaluation, again, it's another aspect that can help us to evaluate pain. The onset of the problem is the O. When did it begin? What provokes it, or the palliative factors? What either provokes it or makes it feel better? What's the quality? How sharp is the pain? How dull is it? How long does it last? The Q is the quality. What is the quality of the pain? Is it dull? Is it achy? What region, or does it radiate to some other part of the body? How severe is it? What the time process is, in other words, how long does it last, or what time of day does it occur? Different associated symptoms occurring with it, or pertinent negatives that goes along with it. So in the behavioral observations, we look at certain different things. We look at whether somebody vocalizes. Do they scream? Do they cry? Is it bad enough for them to cry? Facial expressions, and we all have to be aware that individuals bring certain things to the table, and we have to evaluate those, and we have to really observe. Many years ago, there was a baseball player, Yogi Berra, who had an expression. He had many expressions, but one of them was, he said, you can see a lot by looking. He said, and ultimately, that sounds pretty silly to say that, but it means that we do have to observe. We have to observe the facial expressions, the frowns or the grimaces. We have to observe the body position of our patients. Are they looking different than when they last came in? Are they cringing? And we have to look at the movement responses, the restlessness, the decrease in movement, or the increase in movement for that matter. Other ways that we look at pain are physiological measurements. We observe, is the skin flushing? Is it reddened? Are they restless? Do they have a quicker heartbeat? Or do they have a slower type of a breathing? Is their blood pressure elevated? How many of us take blood pressures? I think it's a very good thing to do that, to observe and evaluate our patients. In infants, it's much more difficult. Most of us don't see infants. I'm a pediatric dentist, so I did see many infants in my practice many years ago. But there's a neonatal infant pain scale. It's called NIPS, and it's the acronym for that is CRIES. Is the infant crying? Do they require oxygen? Do they have increased vital signs? What is their expression, and what's the level of sleep? All of those are evaluative processes in order to determine what level of pain the individual, that infant, is in. In children 1 to 7 years old, there's a different pain scale. Again, it goes by crying, and oftentimes we'll see that in an individual. Facial expressions, what the child verbalizes, how their torso is positioned, whether they respond to touch, and ultimately if their legs are moving in a very fast way, that will indicate that the pain is rapidly increasing. Again, we have a FACES scale for children greater than 3 years old. From 0, does it not hurt? In other words, they're smiling. That's our ultimate smiley face. To 5, the crying and the frown and everything like that, that hurts the worst. And we can make those determinations. And as I said before, that is the visualization. That is something that we have to look at the individual to determine how much pain that they're reporting that they are in. Adult pain, we usually ask them to rate it on a 10-point scale. I write 11-point scale here because most of the people will write 11 as their ultimate intensity of pain, but 0 would be no pain, 10 would be the most pain imaginable. And again, that's the visual 10 scale. We can ask a word graphic scale. Is it no pain, or is it the worst that they've ever imagined, or something of that nature? And then there's a multiple assessment scale. But again, overall, the important factor is evaluating that pain, assessing it, and then we can make the determination how to manage the pain. In this section, we're going to discuss the variation of ways that we can manage pain. First, let's address some of the non-medication therapies. Recognition, empathy, in other words, understanding that our patients can be in pain, and sometimes just that simple talking and understanding of their feelings can minimize some of the pain. Distraction. Being a pediatric dentist, this was one of our major methods of alleviating pain in children. Muscle relaxation, position, comfort. Sometimes if we just adjust things a different way, then, and we find that obviously with the adjustment of occlusion, sometimes can cause the reduction of pain dramatically. Temperature regulation. Is it too hot? Is it too cold? Physical therapies also may work, and ultimately it's treatment of the underlying cause. There are some key concepts that we have to deal with in pain management. And the regulatory agencies, our dental, our medical health care providers, patient advocates, have to understand each other's concerns. And they're getting much better at doing that in terms of interrelational advocacy. Certain options of drug treatment, pharmacologic and pain management, there are many. There are the anti-inflammatory analgesics. There are the opioids, which is, again, one of the main reasons that we're here. Antidepressant therapy, again, we don't see that much in dentistry, but certainly some of the muscle relaxant therapies we do. This is a picture from the Journal of the American Dental Association of July of 2011, and the cover of the magazine talked about prescription or opioid abuse. The article is very worthwhile. It has many different good aspects to it, some of which are the statement on the use of opioids from the American Dental Association, the considerations when prescribing opioids to dental patients, and it goes into about 7 or 8 different items. The definition of terms, the non-medical terms to the use, In other words, the misuse, abuse, addiction, physical dependence and tolerance, which we're going to get into, and then a screening model and a brief intervention and a referral to treatment model. So these are all things that should be employed in all of our dental practices. We get into this discussion of tolerance, physical dependence, and dependence or psychological dependence, and they're all different. Tolerance and physical dependence are not equated with psychosocial or psychological dependence. Tolerance is a normal physiological phenomenon in which we need increasing doses to produce the same effect. And that's something that all of us may have experienced over time. We just build up a level where that drug doesn't work any longer. And so consequently, we need to increase the dose. Physical dependence, on the other hand, it's something that's, again, normal. It's physiological, in which the withdrawal syndrome occurs when something is abruptly, an opioid in particular, is abruptly discontinued or the antagonist is administered. Psychological dependence and addiction, that's a pattern of drug use characterized by continued craving for the opioid, compulsive drug-seeking behavior, leading to overwhelming involvement in the use and procurement, the getting of the drug. In other words, the asking for it specifically in the office. So we have distinct definitions of tolerance, physical dependence, and addiction. And there's much confusion and misconceptions. But the the American Pain Society and American Academy of Pain Medicine have defined the terms. They talk about physical dependence versus addiction. And they agree that most of the patients, most of us who have been patients, and most of our patients who undergo long-term opioid therapy usually develop physical dependence, but we don't really get the addictive aspects. However, we are fearful of causing addiction, and the fear of causing opioids is a major barrier to appropriate pain management. So that's something that we're balancing, the fear of causing that addiction versus the usage and prescription of the opioids. But research has shown that there was a low and stable abuse of opioids between 1990 and 1996. So again, we have some documentation and documentary evidence that this is not causing addiction. However, we're still fearful of allowing our patients to become addicted to these types of drugs. In the tolerance, physical dependence, and addiction, there's low opioid addiction rates in the patient treatment. Once again, tolerance is a state of adaptation in which exposure to a drug induces changes that result in a diminution of one or more of the drug's effects over time. In other words, the drug is losing its effect, and the patient may require more of that type of a medication. Physical dependence is a state of adaptations manifested by a specific withdrawal syndrome. In other words, the actions and the feelings of the individual react to the loss of having that drug in their system. Physical dependence is not addiction. A withdrawal syndrome is to be expected after we use opioids for a long period of time, and there's a sudden dose reduction. Pseudo-addiction is a little bit different. It's an iatrogenic syndrome, a doctor-caused syndrome, resulting from misinterpretation of relief-seeking behaviors, as though they're drug-seeking behaviors that are commonly seen with addiction. In other words, the individual who's looking for the drugs just for their own pleasure, let alone for the reduction of pain. So the relief-seeking behaviors resolve upon institution of effective, in other words, appropriate analgesic therapy. Addiction, however, has several components, and they can be defined as primary, chronic, and many different ways that way. Addiction will include any and all of the following: loss of control over the drug use, compulsive use, continued use despite harming either themselves or other individuals, physical and psychological craving. So again, these can be in combination or they can be individual, but most of them will be in combination, and these are the addictive behaviors. The risk of addiction, however, is low if appropriate levels are maintained. In other words, if we don't overprescribe, if we don't underprescribe, if we prescribe correctly, and give the appropriate medication levels, the risk of addiction is low. However, there are pain management challenges and deficiencies. Some of them are the failure to properly assess the pain. That's really critical. If we don't assess the pain, as we illustrated earlier, and give it its proper ranking and then prescribe properly for that, then we can run the risk of increasing the pain management treatment. There are many difficulties in assessing the pain because the individual may not report properly. Many of our patients are fearful when they sit in a dental chair. So consequently, our difficulty in assessing the pain is really pretty dramatic. There's also a lack of pain relief standards. As we all know, we've all gone to different dental schools. We've all gotten different education with respect to medication prescriptions and different things of that nature. And there's lack of standards in terms of exactly what should be done for which case. And unfortunately, there's a lack of provider accountability for effective pain relief. In other words, we all operate individually. So consequently, the issue of our accountability is only to ourselves. And really, truly, there's really poor reimbursement for pain care. In other words, in dentistry, if we don't perform a service, we typically don't receive reimbursement for it. So consequently, by us administering the appropriate pain management for our patients, we don't really receive any reimbursement. Some of our other healthcare professional pain management issues, a lack of knowledge and proper training. Again, I emphasize to all of you, go out, seek as much as you can in continuing education. This is vital to all of us progressing and having the most knowledge. Another barrier, our most formal decisions with chronic pain with opioids made by the dentist. Almost no formal management is done in any of the curriculums in the dental schools. There are many misconceptions and fears too. Many of us feel that poor pain management, most of us providers really have additional misconceptions and fears that our patients are becoming tolerant or becoming addicted to drugs. And we also fear the regulatory agencies, and as we well should, because virtually everything is computer-based. Whatever prescription that we write is recorded somewhere. Many of us don't realize that, but that is something that we should be aware of. We also have a lack of knowledge and proper training. And in dental schools, there's very little training done with that. There's also a poor, with most of us, a poor communication between us and the patient. And some of it may be language-based, some of it may be cultural, psychological illnesses. In other words, our medical history is vital to what we prescribe and what we evaluate as far as pain goes, but most of us just take that initial medical history and then we don't really rely on it for the patient treatment. We should be continually updating things like that. And then some of the patients may be reluctant to report pain to us. Okay? They feel bad about telling us that things hurt or bad about side effects. So in other words, our communication is vital to the proper pain management. There may be some financial barriers, lack of insurance, cost of medications. All of these can negatively impact how we provide pain treatment for our patients. And then there are legal issues. Again, the major one is the fear of regulatory scrutiny. Okay? That is a big barrier, and we have to abide by the Dental Practice Act, as well as we're also concerned about the legal and societal issues, the legal and ethical concerns of prescribing opioids. These are becoming increasing in our society. Regulatory agencies looking at us, the dental associations, the Dental Practice Act that we each abide by in each of the states where we're licensed, the federal, the state organizational levels. All of these have their legally binding guidelines, and several specifically address the use of opioids in the dental practice. the Federal Controlled Substance Act. This is something that we all have to be aware of. Any of us that have a prescription pad and have a DEA number and a controlled substance number have to know that we are being guided by this Federal Controlled Substance Act. It outlines the essential and legitimate medical purposes of controlled substances. It doesn't tell us what we should prescribe, and it doesn't address our judgment. So consequently, we are the ones who are making the judgment ultimately, and that really is the critical issue. The Controlled Substance Act outlines the essential, legitimate medical purposes, or dental purposes in our case, for controlled substances. And additionally, it guides the health and general welfare of the public. So in other words, that we don't overprescribe. As I mentioned earlier, all of the prescriptions are regulated. They're not regulated, but they're seen on a computer system somewhere. There are national organizations who have position papers, like the Joint Commission. They have their position paper, the American Pain Society, and I've outlined the websites for them, as well as the American Academy of Pain Medicine. All of these are wonderful resources that can be used for the positions and purposes of the opioid prescriber. In this next section, we're going to look forward. We're going to look at how we can improve care, what our licensing board pain guidelines may be, and the increased knowledge that we have over what we had a number of years ago. So we get specific, diagnosing oral, facial, and dental pain. Again, we come back to the acute versus chronic. Acute is associated with tissue, damage, injury, maybe of recent onset, limited duration, and certain stimulation may occur with that. Chronic pain is prolonged persistence, pain beyond the healing of the tissue, frequently in the absence of peripheral stimulation or lesions, can result from changes. Okay. Urgent dental problems are most often acute. They occur from the teeth, the periodontium, lymph nodes, muscle, bone, blood vessels. Toothache is one of the most common acute pain complaints in the orofacial region, and that's something that we all are experiencing and have experienced on a daily basis. Toothache behavior can be very varied though, and so we can't really assume that it's from the teeth until we prove otherwise. The first step is to classify the type of pain based on the history and clinical. The various tissues. Could it be muscles, glands, blood vessels rather, mucosa? Again, we get into the somatic pain, results from stimulation of the normal neural tissue. Could be superficial, could be something like a canker sore, an aphthous ulcer, right? Stimulating, easily localized. Or it could be deep, internal structures. Could be dull, depressing, hard to localize, hard for the patient to refer to us. Deep somatic pain could be musculoskeletal, could be visceral. In musculoskeletal, we see the biomechanical. We say the pain proportional to the movement. In other words, the individual is moving and that causes more pain, and the source can be localized. In visceral, it's not perceived until a certain threshold is reached, until a certain level of activity is there, and it's not stimulated by biomechanical function. It may be diffuse. It's much more difficult to localize. The neuropathic pain arises from the abnormal nerve tissue. Non-painful stimuli now are painful. Things that didn't hurt before now hurt, so the patient reacts to them. They can be episodic. Okay, it can come and go, or it can be a continual nature. Example of that is trigeminal neuralgia. A light touch, okay, can cause a severe pain. Acute orofacial pain could be somatic or neuropathic. Toothache pain is usually from a tooth, visceral, pulpal, in other words, from the diseased pulp, or musculoskeletal. When a pulp is exposed, it reacts and it has an inflammatory response. The resulting swelling, it's unable to expand, and that causes an increased blood flow, which causes a severe type of pain. And all of us have seen in our offices an individual who experiences a toothache. It does not go away with just the administration of a pain medication. So the diagnostic process includes a systematic approach. history and clinical examination. The history is much more important. So the history of the physical illness, HPI, that we see here, is vital. Where is the location? Where is that occurring from? When did it occur? What's the timing? What's the quality? Is it sharp? Is it dull? Is it throbbing? These are all questions that we should be asking our patients. What's the intensity level? What relieves it or what makes it worse? And what are associated? What other symptoms has this brought on? So a toothache, here's a little flow chart. A toothache, again, we show right underneath that the history and clinical findings, and then we go on to, is it consistent with tooth pain or not? And we go right down the lines there. So acute versus chronic, the history and physical. How did it start? Describe it. How intense is it? What aggravates it or what makes it better? How does it affect your life? How does it affect that patient's life? And what are the physical findings? Then we get into the treatment, the pain medications. Okay, here are some simple ones, and we know the acetaminophen, like the Tylenols and the like. PO, 10 to 15 milligrams per kilogram every 4 to 6 hours. Again, there are certain loading doses. Ibuprofens, the NSAIDs, pain medications, the opiates. If one doesn't work, try another. Codeine is weak. Morphine is much more aggressive. And now we show the specifics, the acetaminophen mechanism. We really don't know how it works, but the most common route for it is oral. It has a variable half-life. There are certain contraindications if somebody excessively uses alcohol or something of that nature, but Tylenol is a very effective pain reduction medication. The salicylates, these we've used for years and years and years, the aspirins, and we show those. Some of the contraindications, if there are some induced asthmas or something of that nature. The NSAIDs, the Aleve, the Advils, the ibuprofens, okay? These have been shown to be almost as effective as the opiates if administered properly. And the NSAIDs, what they do with a tissue injury, they release the phospholipids and the appropriate acids, and they reduce the inflammation. So these are very, very effective treatments and should be considered as part of the usual armamentarium of the dentist. Now we get to the opiates. Their mechanism, they variations on opioid receptors and mixed antagonists. In dentistry, they're usually given PO. The side effects, sedation, respiratory depression. Those are pretty aggressive. Constipation. Well, a lot of the medications can cause constipation. Itching, constipations. Well, if someone has COPD, hypotension, absolute, if they have hypersensitivity to and respiratory depression. So consequently, we have to take that full medical history, evaluate whether the opiates are appropriate, number one, for that individual, and number two, for that pain that they're experiencing. We also have some topicals, and these are done more for the local receptor effect. They're either the patches or the local creams or something of that nature. So again, they will release into the body, but they're not as typical a usage in dentistry. We have some adjuvants, some things that can be added to other medications that will potentiate their effects, that will increase their effects. And we see some of these. Caffeine, we can see that listed here. It's very useful with the NSAIDs, like the ibuprofens. Things we shouldn't use acutely are the benzodiazepines, the antihistamines, and the steroids, and different things like that. So a general approach. If someone is on chronic pain meds, then you continue them. Okay? Again, this is virtually unseen in most of our dentistry. It will occur sometimes with the treatment of the TMJ, where some of the people will be on that. With mild pain, again, we try either the aspirins or the ibuprofens. If it's mild to moderate pain, well, as scheduled scheduled type of an ibuprofen, or we could progress to the opiate. Moderate to severe, again, we'll get into the opiates. And again, what I suggest and what is suggested routinely is that we don't give meds, as we see on the bottom here, we don't give them PRN, in other words, as necessary. If we leave that up to a patient to make the determination, inevitably they will make the inappropriate decision for themselves. So it's best to direct the patient to take the medication, either one tab every 4 hours or one tab every 6 hours, however you as the prescriber define that, but not to leave it up to the patient to determine if they're in pain to take it. Because if they do, what we run the risk of is that they will not take the medication when it's necessary, will get into a pain type of a syndrome where they will need more and more to get them out of pain, and then we run the risk of not treating their pain appropriately. As an example, treating some musculoskeletal pain, we have a back strain. Can be treated with something like an ibuprofen, not narcotics, okay? And the dosage would be 400 to 600 QID. Naproxen, which is our Aleve, watch for side effects, okay? There are different charts that we can show for the doses of the opiates that are recommended. The narcotics, they will produce different overdoses like depressed mental status, pupils that have really gotten narrow. Withdrawal will cause things like appetite suppression, diarrhea, tachycardia, the speeding up of the heartbeat, insomnia. And again, we may have experienced these with some of our patients as they go along. We get into the drug schedules. Schedule 1 is non-medical use. It's the heroines, the marijuanas. Schedule 2, this is the high abuse potential drugs. These are the opiates, as we see them, like opium, morphine, codeine, hydromorphone, and the cocaines and the like. Schedule 3, these are less potential abuse, and there's some of the barbiturates. Schedule 4 are the ones that we see quite a bit in use in the analgesic effects in dentistry, the phenobarbs, the chloral hydrates, the Valiums, and different things like that. So again, it's important to understand what you've signed up for when you have that DEA number. So we look at, again, the drug schedules. Refills for Schedule 2 drugs are not permitted. Refills for Schedule 3, 4, and 5 drugs are permitted. That is something that we have to realize. 5 refills is a max. Script will expire in 6 months. No refills over the phone or for someone else's patient. So again, this is something that really is vitally important. I encourage people, try not to prescribe over the phone. Do not prescribe for anybody that you don't know. Do not prescribe for anybody without a dental record in your office. Do not prescribe for anybody for non-dental reasons, okay? We're dentists. We prescribe for dental reasons. I've seen too many dentists get into problems for prescribing for non-dental reasons. One of them was a gentleman who contacted me. His assistant got into a car accident on the way to work, and she came into work. It was a fender bender, and there was no real issue with her working that day, but at the end of the day, she said she didn't feel well. And she didn't have a chance to get to the physician, so she asked him if he could write her for 6 Percocet. So he did. Okay, and she came into work the next day and every day thereafter. 6 months later, he got a call from a pharmacy in town saying that she was using his prescription pad to write prescriptions for herself, and that they were going to file charges. Well, he called her up and told her that he couldn't have her work for him anymore. And so he let her go. And she went right to the authorities and said that he wrote her prescriptions unrelated to the delivery of dentistry. And you know what? Everything else that she said could be denied, but he couldn't deny that. So if anything, if you write a prescription for someone, make sure that they do have a record in your office. So in coming to conclusion, we first evaluate the pain. We look for the underlying causes, assess the pain. Next, we identify the treatment options. Can we do it without drugs? If we use drugs, how do we use the drugs appropriately? Or do we have to get into more invasive therapies? The non-drug therapies, ice and heat, exercise, rest, TENS units, we didn't go into that before, but the electrical stimulation, again, they're becoming increasingly in dentistry. The universal principle is believe the patient. Understand that unless you have reason to disbelieve, believe them that they are in pain. Some other considerations, it's a trial and error process. We don't always know exactly what it is. Show your patient that you're willing to work with them and try to have some realistic expectations. We can't cure everything. We can't do everything perfectly. Prescribing opioids safely, short acting. Their PRN have their place, but it's just for acute pain. For breakthrough, for moderate pain, chronic pain, round the clock, tell the patient when they should be taking them. Some more important issues with the opioids, understanding, as we explained earlier, the difference between tolerance, physical addiction, and physical dependence and addiction, knowing the difference between addiction and pseudo-addiction, and anticipating and preventing some of the side effects. If you do prescribe opiates chronically, which I don't encourage, please document the 5 A's at each visit. The analgesia effect, the activities for daily living that person is experiencing, any adverse effects, anything that you see as aberrant, anything out of the ordinary for drug taking, and the affect of the patient. In other words, how they appear to you. Prevalence of chronic pain, in review, we showed that 9% of the US adults have pain of a chronic nature. 78% of adults in this country will report that they're in pain today. 56% will say that they've had pain over 5 years, and 55% say they, quote unquote, have it under control. Evaluate the underlying and treat the underlying cause. Treat the pain, listen, trust your patients, use all your resources, refer if you get stuck, but stick with your patients. In summation, I've got 7 fast facts that we look at. They are the critical components of pain assessment, the types of pain, the World Health Organization's stepladder of analgesic medication, and this is something that most of us are not aware of in dentistry, the general guidelines for analgesic medication orders, the dealing with neuropathic nerve-type pain, the dentist and physician communication, because that is important in the chronic pain type mechanism, and how to increase an opioid dose. So number 1, you have to do a pain assessment. Components, we went over them before, the location, the duration, the onset. I'm not going to dwell on them again. Number 2, there are 6 types of primary pain, the visceral, muscle, bone, neuropathic, pleuritic, and colic pain. Visceral pain, I ache all the time. Muscle pain, I'm sore and stiff. It feels like a Charlie horse. Bone pain, okay, it hurts when I move. It aches all night. Neuropathic, feels like my skin is burning. Feels like someone stabbed me. Pleuritic, pain is worse when I breathe in. In other words, that's something that probably is not of dental origin. Colic pain, it comes and goes like cramps. Well, you know, obviously our patients are individuals. Their digestive process may not be working properly. There may be an underlying cause, and they may be coming to you and not be going to their physician. Number 3, this is the World Health Organization, not the singing group, the World Health Organization analgesic ladder. And the ladder looks like patients with mild to moderate pain, non-opioids, patients who have limited opioid exposure, they have moderate to severe, and patients with severe pain fail to achieve relief with the administration of drugs should receive an opioid conventionally used for more severe pain. Number 4, general guidelines for analgesic medication orders. Medications should be administered routinely, not as determined by the patient. Use the least invasive route of administration first. In other words, PO is what we always use orally. Begin with a low dose, raise it until comfort's achieved, reassess and adjust the dose to optimize the pain relief. Critical points for the analgesic medication orders also include the character and quality of the pain, and oral route again is the first choice. Only one combination of analgesic opioid and non-opioid, Vicodin, Tylenol 3, is ordered for PRN breakthrough pain. Only one, okay? Short-acting opioids are ordered at intervals no longer than 4 hours. In other words, if we go longer than that, we run the risk that the pain can increase and we might not be able to get ahead of it. Dose escalation is calculated as a percentage of the current dose. In other words, roughly we can go up 25 to 50% or 50 to 100% if we rate the pain, as we showed earlier, in the 3 to 6 versus the 7 to 10 range. Frequency of dose escalation is dependent on the opioid preparation and dose. Orally, usually 1 to 2 hours of short-acting. Definition of neuropathic pain, I'm not going to go into that again, but I'd like to refer to it right at the end. Distinct features of neuropathic pain. It can be bilateral, okay? Pain will give clues to the best management of the pain. Management options, opioids, antidepressants, which we don't really utilize in dentistry, anticonvulsants. If they don't work, sometimes a local anesthetic may. Number 6, communication steps. Identify the physician in communicating with a physician. Identify your physician by name, give your name, state the general nature of the call, identify the patient by name and the diagnosis, state the pain management goal, summarize the current pain ratings. Again, we went into those ratings earlier. Please get familiar with them. List the current analgesic dose and the side effects, and suggest a solution. Okay, that's you're the prescriber, you're the treater. Make sure that you suggest a solution. And finally, number 7, guidelines can help in the understanding of opioid dose escalation. Review the guidelines for opiate use escalation before discussing your recommendations with the physician. Finally, with the guidelines for the analgesic escalation, it again is done as a percentage increase. Going from 1 to 2 tablets will represent a 100% increase. In general, patients do not notice a change in analgesia when the dose increases are less than 25% above baseline. So in other words, going for a quarter increase is not enough. We generally have to go at least to a 50% for moderate to severe pain. Dose escalation. In summation, what we've discussed here today is the appropriate ways of defining pain, evaluating pain, treating pain, and again, that is subjective because each of us are different prescribers, each of us are different treaters, and each of us have a different patient community that we deal with. So your patient community is important to your office. Please take your time, do a complete medical history, evaluate, and then you can finally counsel the patient that any of the unused medication should be discarded. It can be brought back to the pharmacy. It can be discarded appropriately through mail-back types of systems. And if indeed you do keep any controlled substances in your office, please realize that there are certain obligations under the Drug Enforcement Act that you have to abide by in order to maintain these types of medication in your office. I thank you for your attention, and I welcome you to view any of our additional videos.